Yep, yep. And
That's
we wanted
awesome.
like strong female names. My last name now is Murphy, which I love. It's so much easier than Sierra because nobody ever said my maiden name correctly. Um, I actually should update this slide. It's so funny. So we got married in 2022, and at that point, I already established myself in my career, so I didn't want to drop Sierra because
Sure.
everybody would be like, "Who the heck's that lady?" But every time, he sees, he's like, "Are you ever going to drop your maiden name?" And I think I'm finally ready to drop it. So I should have actually removed it from this slide, but maybe next time.
Well, it's funny. I think you removed it when you sent a couple bio things. Because when I was preparing your bio, I just have Murphy. And it's funny because I was thinking, I wonder if I should ask her if I need to add that part back in
No, my
or
husband would be very happy to know that I'm being introduced as Brittny Murphy.
awesome. Well, good. Hmm. Well,
Cute.
if anybody feels like they want to turn their cameras on, you can do that now or later. Brittny says that she will take questions during our presentation as well as after. So everybody should be able to turn their cameras on or write in the chat. The chat is where I will actually be posting the CE at the end of today too. So why don't everybody just get familiar with the chat now? I'm just
Do
going
you
to
think
type
that
in.
everyone could also put in there their background, like if they're, a doc or hygienist
Yes,
or assistant or whoever? I always love to know who's listening.
I'll start. There we go. Christina, hygienist. Thank you. Who else? Find the chat and ooh, dental hygienist from Appleton, Wisconsin. Erica,
Ooh.
hygienist. Lots of hygienists this morning.
Oh, that makes me happy.
Awesome. Who else? Everybody clinical so far?
How about anyone that is an RDH? Are you also a myofunctional therapist? Or I'd love to know if you have any familiarity. I can never say that word. Familiar. How do you say that? Familiar.
Oh my gosh, familiarity. I messed it up too.
That's too funny. Not just me. That makes me feel so much better, Angela. Thank you.
There's a few words I can't say and a few words I can't spell. And if I took 5 minutes and figured out what they were or how to do them, it would probably save a lot of embarrassment in the future. But
That's too funny.
a
Oh,
couple
Kelly's office
dentist.
already has a Myo program. So, oh, you're excited to learn more. I'm so excited you're here, Kelly. Dr. Smith.
From Alice, Texas. Awesome.
Hi,
That's
Erica. Awesome.
that's the great thing about virtual courses is you can get people from all over. I was in Chicago last week for Chicago Midwinter,
Mhm.
and it's funny, like post-COVID, CE is very different in
Hmm.
that I'm very choosy of what I want to see in person now.
Yeah,
So I like the more interactive, more, engaging. If I'm just going to watch someone behind a podium,
you can do it
I
from the comfort
I
of your
can do
home in your
it
jammies.
in my pajamas. Yeah. So awesome. Well, I am going to introduce you. I'm going to read your bio and then I'll let you take over. And if anybody else is just popping on now, what we're doing is finding the chat and adding um, our department or our title into the chat, and that's where you'll find the CE later. And I keep muting a couple people because there's just a little bit of background noise coming through in case you're wondering. All right, there we go. So it is my pleasure to introduce Brittny Murphy, a registered dental hygienist, myofunctional therapist, educator, and key opinion leader in sleep and myofunctional therapy. As the founder of CT Orofacial Myology and co-founder of MyoAir, Brittny has helped countless patients improve their sleep and breathing. She is also on faculty for Airway Health Solutions, training healthcare professionals in myofunctional therapy, And if that's not enough, she's the voice behind the podcast I Spy with My Myo Eye. So please join me in welcoming Brittny Murphy.
Oh, thank you. I am so excited to be here today and to have all of you joining me and spending the next 2 hours discussing how we can begin incorporating a myofunctional referral and screener into your practice. For those hygienists that are listening, I already want you to know I'm not going to add on minutes upon minutes of your already very busy time that you spend with your patients. This is all things we can be screening for when we're doing our EOE, IOE. So I always like to start off the conversation with that because I'm a hygienist. That's my background. I understand having multiple things to do in that very short time that we get with the patient. So I just wanted to put that out there. All right, so let's get started. So Angela already did a fabulous job introducing me. So I'm Brittny. Again, thank you for being here. Can you guys, I keep getting pop-ups about people being in the waiting room. Are you seeing that on my screen? Okay, let me
I am
open
sorry. I'm
that.
letting people in as fast as I can get them.
Okay, no worries.
You don't have to worry about
Um,
that. Andy and I will take care of everybody.
okay, cool, cool. All right, so today we're gonna learn how to spot early signs of airway issues, tongue ties, and improper oral habits. We're going to implement a seamless myofunctional screener during hygiene appointments. We're going to educate patients on the importance of proper oral and facial function and position ourselves as a vital link in interdisciplinary patient care. So I don't want to spend too much time talking about more of the foundations of Myo. If anybody has more of an interest, please reach out to me, afterwards. I'll just give a little bit of a brief background, just for those of you that aren't familiar with it. And then again, reach out to me. I have a private Facebook group called the Myo Hygienist, if you want to learn more. So you're going to hear these terms used interchangeably: myofunctional therapy, oral facial myofunctional therapy, oral facial myology. Some people call it OMT, some people call it Myo for short. Generally speaking, these are all interchangeable. And if we were to think about I'm going to give you the technical definition, and then I'm going to give you an easier way to explain it to your patients. So I really like the definition by the AOMT, which is the Academy of Oral Facial Myofunctional Therapy. And they explain it as the neuromuscular, I want to like bold, italicize, underline that word, the neuromuscular re-education or repatterning of the oral and facial muscles. So our therapy includes exercises, facial exercises, tongue exercises, really everything below the eyes and above the shoulders, along with behavior modification techniques to promote what we call proper oral resting posture. So that means where your tongue is resting, where your lips are resting, where your teeth are resting. We're going to go over that shortly. And we work on breathing patterns, so making sure we're breathing in and out through the nose. And we also assist in making sure our chewing and swallowing patterns are optimal as well. What we want to make sure is we want to create a harmonious balance between those oral facial muscles by removing any unintentional pressures that are being put on the dental arches. So we want to make sure everything's balanced out. When we're speaking with patients, a simple way to explain it, so you will hear some people say that it's like physical therapy for your mouth. Now, again, my background's in hygiene. I'm not a physical therapist, so I don't really love to use that term, but patients do get it easier when you say that. But sometimes I just feel more comfortable comparing myself to more like a personal trainer. Like think of me, personal trainer for the muscles below the eyes and above the shoulders. Now, when you do use that analogy as a personal trainer, everybody's next question is usually, am I going to have to do these exercises for the rest of my life? My child's only 7 years old. Is he going to have to do these forever? And that's why I said before, highlight, italicize, bold the word neuromuscular reeducation. Neuromuscular meaning we are creating new neural pathways between the brain and the muscles. So we are creating new habits, forming new muscle patterns that are lasting. Okay, so that part is very important. When we're talking about myofunctional therapy, yes, we have that neuromuscular reeducation, but if we're not being compliant, myofunctional therapy is a very, very compliant-based therapy. I could be the best therapist that ever existed on this planet, and it would not matter if my patients were not being compliant. So we're giving exercises, homework, if you want to call it. I don't usually like to use that term because then it makes people not really want to do their exercises. But it is making sure that they're practicing. It's usually 2 to 3 times a day, not a long time, maybe 5 minutes in the morning, 5 minutes in the afternoon, 5 to 10 minutes at max. But the other really important part, we can't just focus on the exercises because we're doing them what? Let's say we're doing our exercises. It shouldn't take this long, but let's just say 30 minutes out of the day for the sake of math in my brain. What are we doing in the other 23 and a half hours of the day? How are we positioning all these muscles? That self-awareness of pretty much your entire body. I mean, of course, we're focusing more on this part, but really the entire body. We need to build an awareness into that. We could have great posture when we're doing our exercises, but if all throughout the day we're sitting slumped over, if you slumped over right now, you can kind of feel like everything in your mouth start to follow along with it. It's very difficult to keep your tongue up if our posture is not supporting it. Regardless of who I'm working with, I have goals that I want each of my patients to accomplish before they graduate from my program. That's establishing dominant nasal breathing all day and all night, attaining a competent lip seal all day and all night. And the reason I'm saying all day and all night is because during the day, we can be aware of how we're posturing things, but at night, it's obviously very difficult. So we have to learn to kind of tap into that subconscious a little bit. Sometimes we have to use different adjuncts or aids to help us establish those postures so that we can create better habits while we're sleeping. We want to create a palatal tongue rest position. So the tip, the middle, and the back of the tongue should be resting nicely up in the roof of the mouth. And I'm going to have a slide to show you like how much of the tongue should be up there. The very tip of the tongue you want right behind your upper front teeth. So the technical location for the tip of the tongue is on the posterior third of the incisive papilla. If you were to say the letter N, where the tip of your tongue elevates when you say the letter N, that is where the tip of the tongue should be, and then the rest of the tongue should follow suit up there, lightly suctioned. We work on developing bilateral alternating mastication patterns. The way we chew is extremely important. I want to say it's like the first 5 chews that are the most powerful. So that's why we want to make sure not only as we're chewing that we're alternating and moving the food, lateralizing it side to side, but even that first bite that you take, making sure you're not one side dominant, okay? And the reason for this is we want to create from a very young age good bone loading between the maxilla and the mandible. When you chew on the left side, it's going to stimulate the mandible to grow on the left side and the maxilla to grow on the right. And then vice versa, when you chew on the right side, it stimulates the mandible to grow on the right and the maxilla to grow on the left. So we have to be balanced there. We work on optimizing swallowing patterns with a back teeth together swallow. The only time, and I quiz all my patients on this, the only time that your back teeth should ever touch is when you swallow. And almost all of the TMD patients that I see have a dysfunctional swallowing pattern with their back teeth not resting together when they swallow. They typically have a tongue thrust going on as well. We'll get into that a little bit. And we also work on eliminating noxious oral habits. So again, regardless of the age, I've had patients in their 40s that are thumb suckers, finger suckers, nail biters, hair biting, literally putting in pens, pencils, clothing, anything in the mouth that shouldn't be there because it's going to displace the tongue, the lips, and the jaw. One of the very important things that we have to make sure we're able to do to be successful in myofunctional therapy is breathe through our nose. If we cannot breathe through our nose, we will not be successful with myofunctional therapy. So one of the things that I implement with every single one of my patients, regardless of them being a nasal breather, mouth breather, have allergies, don't have allergies, I don't care who you are, every single person should be practicing nasal hygiene. That is like telling somebody, well, you have a very low caries risk, so you don't have to brush your teeth, or you don't really have BO, don't bother taking a shower, right? We do these things preventatively, and it's the same thing with our nose. So I really like X-Clair nasal spray. Some people call it Claire. I call it X-Clair. It has an X in it because it has xylitol in it, which is an antimicrobial agent. Babies can use this nasal spray. It is very holistic, very safe. There is a different bottle for babies that isn't, or younger children that isn't as pointy. AYR ear, insanely nasal gel. I'm a big proponent of that as well. If you have seasonal allergies, anytime that you're going outside, just kind of line your child's nose with some of that nasal gel. That can be very helpful. And then aromatherapy inhalers, I also love to incorporate. These are just two examples of them. One is called a neti stick and one is called a boom boom stick. I want you to take a second and I'd like for you to just breathe in and out through your nose for me. Just take a breath in and take a breath out. And I want you to think about, where do you feel your tongue resting inside your mouth? This can be a hard question to ask somebody because it then makes your tongue feel like it's this big elephant in your mouth and you have no idea what you're doing with it, because nobody really ever brings that much attention to your tongue until you start working with a myofunctional therapist. But hopefully you're able to identify where your tongue was resting. As I mentioned, this very tip of the tongue, you want right up at that incisive papilla on that posterior third. And then the rest of the body of the tongue should be lightly suctioned up there. So think about pretty much at the junction between the hard and the soft palate. Usually what I'll do is I'll have people take their tongue and trace their tongue from the incisive papilla till they get to I'll say that soft squishy part in the back of your throat, till they get to that soft palate so they can see how much of that tongue I want up there. This very base of the tongue, which is the posterior third of our tongue, this part really only elevates when we swallow. So we want the tip and the body up there, which is, again, if you think about it, still a very significant part of the tongue. So I'm going to show you what it looks like. Okay, that much of our tongue should be resting up there at rest. You'll see all different variations of that. Some people will have just the tip of their tongue up, but the back down. Some people have their tongue flat in the bottom of their mouth, hanging out in the middle of their mouth, pushing between anteriorly or maybe posteriorly. But that's where we want our tongue resting. So the back of the tongue should be elevated. Our lips should be closed without any facial strain or compensation. So we don't want any recruitment from these perioral muscles. Those back teeth should be about 2 to 3 millimeters apart. So that dental freeway space. Usually I tell patients, like, you want your back teeth pretty much hovering over each other. Okay. We don't obviously want our teeth together. We don't want to be clenching. We also don't want too big of a freeway space because we can cause super eruption. We can cause TMD issues that way. And then, like we discussed, we want that nasal breathing all day and all night. Oh, I have something popping up on my screen. Again, I'm sorry, guys. Let me just move it. Are you guys able to see my screen okay, or are your faces on my screen?
We can still see you.
Okay, perfect. Sorry about that.
No, you're good.
Okay, so dental office benefits. We're going to talk about dental office benefits. We're going to talk about overall health and wellness benefits. So first and foremost, let's talk about improving our bite and jaw alignment. So when we work on correcting our tongue posture, when we work on correcting our oral habits, this can impact the alignment of your teeth and your jaw. It's from a very, very early age going to impact the way your jaw grows and develops. But even as an adult, you can still benefit from this doing myofunctional therapy at any age. So let's say we have improper tongue posture, okay? Whatever it is, low tongue rest posture, a forward tongue rest posture, that can lead to an open bite. It can lead to crooked teeth, malocclusions. I've seen very, very deep bites with it as well. It's not just an open bite. And oftentimes, like, that's like the classic myofunctional therapy patient when you see somebody with an anterior open bite or a posterior, unilateral, bilateral open bite. But even a very deep bite can be due to incorrect tongue posture. Okay. I hate to say this. I mean, I don't hate to say it because it's true, but when I go to do a lunch and learn in an orthodontist office, usually they say to me, like, look, we understand the importance of the muscles. We want to be able to help our patients. Can you just tell me who I should be referring to you? In a perfect world, every single patient that is being seen by an orthodontist or being seen by a general dentist doing clear aligner therapy or whatever it might be should be going through myofunctional therapy. When we think about why teeth move, why jaws grow inadequately, it is due to that soft tissue dysfunction. So we have to get these muscles working in order to see results and especially to see lasting results. Okay. So myofunctional therapy, we're retraining those muscles so that we can support that proper alignment. Things will shift when we're in, orthodontics, clear aligners, whatever. But we want to make sure that those things are maintaining. Okay. And something that you'll hear me say a lot if you ever take one of my courses is form follows function. We have to get the function down. In the same breath, you really can't address one without the other, right? If I'm trying to teach somebody to rest their tongue in the roof of their mouth, but the roof of their mouth is teeny, 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 tiny, it's going to be really hard for me to do my job. So almost always I am working alongside some kind of structuralist, again, whether it's a general dentist or an orthodontist. As I mentioned, we can prevent or even alleviate malocclusion. So by correcting these things at a very early age, whether it's due to oral habits like thumb sucking, mouth breathing, tongue thrusting, whatever it is, we can help reduce the risk of malocclusion, getting to these things as early as possible. In a perfect world, when we look at the primary dentition, we want to see spacing between every single one of those baby teeth, almost so much so that you're able to slide a nickel up between each tooth. A lot of parents, when they see their children having these tight teeth, maybe they're not crowded, but they're close together, they don't think anything of it because that's what we want, right? In our smile. But for children, we would consider that crowded. And when we think about the root cause of that, why those jaws didn't grow big enough to have that ample spacing, it all goes back to that soft tissue dysfunction. Enhancing breathing and airway function. So mouth breathing is like #1 big sign of a myofunctional disorder, okay? And this is common in children and adults. And we know what mouth breathing can do to the oral cavity, right? Increase caries risk, dry mouth. But it's also going to create that narrower dental arch because it does not, if we're breathing through our mouth, your tongue is going to rest in the floor of your mouth. And I'm going to show you how and why. I want you to suction your tongue up to the roof of your mouth like this. Okay. And then I want you to try to breathe through your mouth. If you're suctioning your tongue correctly, you should not be able to breathe through your mouth. Okay. It is when that tongue posture drops that we become mouth breathers. When that tongue posture drops, we don't have anything helping to support the driving force of that natural growth and development of the upper jaw, right? It's the pressures from the tongue anteriorly and laterally that help to grow that jaw, okay? And if we think about what the upper jaw is, it's also the floor of the nose. So if our upper jaw is narrow, our nasal cavity is going to be reduced as well, which is going to impact the way we breathe and oftentimes lead to chronic mouth breathing. So with myofunctional therapy, we're doing breathing re-education. We're teaching the tongue to rest in a proper position so that we can breathe through our nose well.
Brittny, can you do an example of that again?
Yeah, absolutely. Okay, so you're gonna, if you can't just get your tongue up there, think about popping your tongue on the roof of your mouth. So that suction you create before the pop, it's that suction. So hold that suction and then try to breathe through your mouth. You should not be able to. You only should be able to breathe through your nose when you have your tongue suctioned up there. So that's why as soon as that tongue posture drops, for whatever reason, I mean, it could be due to multiple things, which we'll talk about a little bit later, that's when we tend to become more of a mouth breather. Okay, so let's see, where do we leave off? Okay, sleep apnea treatment. So we help with so I hate to say just obstructive sleep apnea, right? Because sleep disordered breathing really should be the umbrella term. I don't want to just focus on obstructive sleep apnea because there are so many patients out there suffering that don't actually get a diagnosis of obstructive sleep apnea, but are still suffering from some form of sleep disordered breathing. Okay. So when we talk about that, we really want to use that umbrella term. But even if you look in research, myofunctional therapy can be very effective with patients with mild to moderate obstructive sleep apnea. If somebody has severe obstructive sleep apnea, especially if they're not being managed, that's not a case that I really want to take on. But through research, they have found that myofunctional therapy or oral pharyngeal exercises is how they refer to it in this particular research study that was done in 2015 by Dr. Camacho. It shows that these exercises can help reduce the AHI, so our apnea-hypopnea index, by 50% in adults and 62% in children. It can also help lower snoring and help with sleepiness, decrease sleepiness levels as well, and increase our O2 oxygen levels during sleep. So whether this patient is using a CPAP, using an oral appliance, a combination. Maybe they're doing CPAP and oral appliance therapy. Myofunctional therapy can help make the appliance more effective and make it more comfortable for the patient. Oftentimes, you'll hear people, they can't stand wearing their CPAP, or maybe they can't stand having their oral appliance in. If we can help work on those muscles, think about those muscles in the oropharyngeal space, tighten up those muscles, tone those muscles, sometimes even learn to activate them well, is part of the problem. We can really help make a difference in our patients that are suffering from sleep disordered breathing. So it's really that multidisciplinary approach, but myofunctional therapy definitely has a spot. We talked about post-orthodontic retention. So regardless of braces, aligners, whatever it should be, in order to get lasting results, we have to create functional muscle patterns, or we will see relapse. We will see teeth shift back out of alignment. So myofunctional therapy can help everything stay in that desired position. What I say to patients, like, first of all, I'm never going to tell somebody that they shouldn't wear that they don't have to wear the retainer. I'm not an orthodontist. I would never say that to one of my patients. But I know as a myofunctional therapist, in a perfect world, our tongue and our lips, these oral facial muscles, are really our body's own retention system. If we have good muscle function, our teeth should not shift. If we have adequate room in our mouth and our jaws grew where they should be, teeth should not be shifting, okay? So we have to correct that underlying muscle dysfunction. We work on preventing or treating TMJ disorders. So we work with a lot of TMD patients. Oftentimes, a lot of that pain is due to improper muscle activity, overuse of certain muscles, just really imbalanced muscle function around the jaw and the face. So myofunctional therapy can help reduce that tension and teach proper jaw alignment, which will then help to relieve or prevent some of that discomfort that is associated. I often see, like I mentioned earlier, swallowing issues with TMD patients, chronic mouth breathing, and sometimes these patients don't know, because when I talk about mouth breathing, oftentimes people think about somebody like with their mouth like wide open. Like I always use like Napoleon Dynamite as an example, but the mouth doesn't have to be open that big to be a mouth breather. Your lips can be parted this much, and you can still be breathing through your mouth. Okay. So chronic mouth breathing, swallowing issues, and I do often see a tight lingual frenum, which we're going to talk about tongue ties later on. We are working on improving overall oral health as well. That myofunctional therapy, creating that strong foundation of muscles, is going to help create a strong foundation of our structure, right? Form follows function. So think about patients too that are clenching and grinding their teeth, right? When we see clenching and grinding, I don't now, if you asked me this question 10 years ago before I became a myofunctional therapist, I would have said, oh, you need a night guard. You're stressed, right? Let's put you in this night guard. And I don't want to upset anybody, because I know that, night guards are a high production for us in dental offices. But we want to get to the root cause of it. Like, why are we clenching and grinding the teeth? We might be protecting the teeth by getting the patient in this night guard, but we're not addressing what that root cause is. So when I see things like, signs of bruxism, worn down dentition, abfractions, I want to know, is there an airway issue that's going on? When I see patients that are active chronic perio, like they're coming for their 3-month perio maintenances. They're doing everything and anything that you recommend, but that disease is still active. Like, what's going on? We have to think about what bruxism can do to the periodontium, right? So we want to just always get to that root cause and not just put Band-Aids over things. The pediatric patients, Myo has a huge place for pediatrics. Now, myofunctional therapy is for patients of all ages, right? I have worked with patients well into their 80s. I think my oldest patient has been 84 years old. She was fabulous. Actually, I had two, I had a male and a female. But when we think about myofunctional therapy, it is based off of principles of neuroplasticity, one of them being age matters. So yes, when you're working with a pediatric patient that is still growing and developing, it is much easier to see their progression. It's much easier to make those changes. So from a very early age, as soon as we're seeing any signs or symptoms of malocclusion, crowding, mouth breathing, if they have a tongue tie, issues, chewing, issues speaking, whatever it might be, we want to get them referred to a myofunctional therapist right away. When we talk about the collaborative care model, so we work in a very multidisciplinary team. I always say to my families when they come in, I am not the only person that you're going to see. Myofunctional therapy is extremely important, but it is an adjunctive therapy. So I'm working collaboratively with dental professionals, speech therapists, ENTs, sleep doctors, PTs, OTs, like you name it. Whoever my patient needs, I'm working with them because I can promise you it's not just going to be me. Okay. So being able to create that team and establish yourself, in your communities and really just have that team where a patient comes in and you know that there's a breathing issue and it's like, okay, well, you're going to send them to Dr. O'Neill and you know that Dr. O'Neill is going to assess them exactly the way they need to be assessed, which sounds odd to say that an ENT might not always assess correctly. But oftentimes, if I'm referring to an ENT that is not one that I work with, parents come back and will say something to me, well, they said that, it's not that bad. And I'm like, well, okay, the opposite of it's not that bad is it's not that good. I don't want my child breathing not that good, right? Or the tonsils and adenoids, it's okay. They'll be fine. They'll grow out of it. They'll shrink as they get older. But how are they impacting the child now? Is the child suffering at night? Are they not able to sleep? So you want to make sure that you form these relationships with different providers in your area. And I promise you, it just helps improve your patient outcomes. And in general, in a dental office, we can improve treatment outcomes. So poor oral habits, muscle imbalances, those are going to really cause havoc with any kind of honestly restorative treatment you do. I think back to this one specific patient that I used to treat in my hygiene chair that I know now had obstructive sleep apnea, but I didn't know then to screen him for it. And he would constantly call that he's breaking this tooth and this crown. And it's like, what is this man chewing on? And what would we do? We would fix the teeth, we'd restore the teeth, and then he would break them again. So we can save our doctors valuable chair time by treating that underlying problem, which again is that muscle dysfunction. Myofunctional therapy, so it goes way beyond oral health into overall health. We already talked about improving breathing patterns. Sleep quality is another big one too. Whether again we're mouth breathing, snoring, upper airway resistance syndrome, full-blown sleep apnea, myofunctional therapy has a place for it. Snoring is not normal under any circumstances. I mean, of course, if you're clogged up because you're sick, that's fine. But snoring on a regular basis, even if dad snores, grandpa snores, uncle snores, that doesn't mean little Johnny should be snoring, right? We want to get to the root cause of it. And with myofunctional therapy and working on our breathing patterns and working on our tongue posture, we can help keep that airway open while we're sleeping. Switching from mouth breathing to nasal breathing, we can help, I believe it's like a 20% increase in oxygen to the brain and the muscles when we're nasal breathing versus mouth breathing. So we don't just want to look at sleep quantity. Like maybe somebody tells you, they go to bed at, I don't know, 9 o'clock and they wake up at 6 o'clock. Okay, but what kind of quality sleep are they getting? Are they reaching all of those levels of sleep? Are they staying in stage 3 sleep, which is our deep restorative sleep, for the amount of time that they should? And myofunctional therapy can really help make a difference. Prevention or alleviation of headaches or migraines. I see this again often with my patients with TMD. So we have to look at the whole picture, right? We're looking at all those muscles that are being impacted, all of the compensation patterns that we see in our TMJ muscles, right? So our masseters, our temporalis. I see a lot of tension in TMD patients with their SEMs, their traps, all of this stuff. And when I am assessing them as a myofunctional therapist and I'm watching the way that they move their tongue and they move their jaw, there's so much instability going on. Their jaw oftentimes is carrying that movement, okay? Or they move their tongue and I see all this muscles. Like when I move my tongue, my neck muscles, you shouldn't see them tighten up like that, okay? If you do, think about all that tension that's going to be created, especially at the base of your skull. So oftentimes we see a lot of alleviation in patients that have headaches, migraines. We work with patients, that have a lot of allergies and things like that. When you breathe through your nose, you have a filtration system in your nose, right? When we breathe through our mouth, we don't have that. Deep in our nose, we have those tiny little microscopic hairs called cilia. Those help to filter out allergens, pollutants, things like that. It preps the air so it's better for our bodies to breathe. We don't have that filtration system when we breathe through our mouth. And myofunctional therapy, part of my job is breathing reeducation. We see improvements in digestive health. We all know digestion begins in the mouth. So if a patient is not chewing well, whether it's due to a tongue tie, jaw issues, malocclusion, whatever the case may be, we're going to see that being impacted. I also have a lot of patients that have tethered oral tissues that suffer from constipation. A lot of little kids that I see, when they have their tongues released and they're able to actually utilize their tongues and assist in that lateralization and moving that food side to side, and they're actually slowing down, and we're able to teach them to chew and actually chew our food, not just chew 2 times and swallow. I like to teach my patients to chew their food about 20 times before they swallow, so it's nice and soupy in the mouth. That is going to impact the way the way we digest in a good way, right? Speech and communication. So I'm not a speech therapist. I don't ever claim to be a speech therapist. When patients call me and they say, well, my child has a lisp or my child struggles with, producing the letter R. Okay, well, what I can tell you is that oftentimes patients that have OMDs, which are orofacial myofunctional disorders, sometimes we see them have speech issues, not all the time. Sometimes people learn to compensate really well. But when we think about the way we talk, I'm talking right now, my tongue is moving and hitting different areas in my mouth. If my tongue can't, because it's restricted due to a tongue tie, or maybe my tongue, I have low tone, I just have poor muscle function, it will impact the way I speak, the clarity of my speech. So sometimes patients even come in that they might not have a speech error, but like they're mumbling and they're very difficult to understand. And oftentimes through myofunctional therapy, we can help people be better communicators. Mental and emotional health. When we think about chronic mouth breathing and overbreathing, there's a big link to higher stress levels, anxiety. When we think about sleep issues, there's definitely a link between sleep disorder breathing and depression. When we think about our nervous systems, okay, when we are breathing through our nose, we're activating our parasympathetic nervous system, which is our rest or digest nervous system. When we're breathing through our mouth, we're chronically in sympathetic overdrive, which is our fight or flight. Okay. Think about the havoc that that's going to create on your entire body, but especially your emotional and your mental health. So, again, if we think about the root cause to this and we make sure the airway is clear and we get these muscles working better and we teach the tongue to rest where it should in the roof of the mouth and we get the lips closed and we get these patients to breathe through their nose and sleep better, we can see a reduction in stress levels, issues with anxiety, and things like that. Facial aesthetics and confidence, and just overall long-term health benefits. When we think about causes of OMDs, just want to be mindful of the time because I can talk forever. When we think about causes of OMDs, oftentimes they are a combination. It can be due to tethered oral tissues, tongue tie, lip tie, cheek ties, a restricted nasal airway, whether that's enlarged tonsils, adenoids, deviated septum, anything that is preventing the patient from breathing through their nose well. Non-nutritive sucking habits like thumb sucking, pacifier use, finger sucking, things like that. And I have lack of breastfeeding on here as well. And the reason for that is the driving force, the difference in the muscle activity between breastfeeding and bottle feeding are very different. Breastfeeding is the most natural form of myofunctional therapy from a very early age. That tongue is learning that nice posterior elevation and suction. And they're getting the benefits from what the pressures from the tongue are naturally doing to the palate as our jaw grows and develops. Obviously, babies' palates are very malleable, but not my place to ever judge how somebody's feeding their child. I'm a myofunctional therapist. I just had twins in August. I would have loved to breastfeed my children. Of course, the nutritional benefits, but also knowing what it can do for jaw growth and development and our overall health. But it didn't work for one of my girls. I nursed one of my girls and my other, she gets my breast milk, but I have to pump for her because we tried and we tried hard, but it just wasn't in the cards for us. And I have all this knowledge, right? I even worked with all the right people, lactation consultants, feeding therapists, and whatnot. But it's not happening, right? So we're never here to judge anybody, but I always think it's so important that these mamas are at least presented with the information to know the benefits of breastfeeding outside of just nutrition, and also to be able to bring that awareness that if your child's not able to breastfeed, they're not able to latch, or your milk supply is low, that can be due to issues like, say, a tongue tie. If a baby can't efficiently latch, supply and demand, right? If the baby's not efficiently latching, that supply is going to go down. And so often I hear from moms like, oh, I felt so guilty. I really wanted to nurse, but I couldn't because my supply just tanked. So again, education is just so important. Myofunctional therapy, typically we're starting at age 5 for a full program, but we do mini myo with kids younger. Why do we intervene early? I didn't learn this in hygiene school. And when I learned this, my mind was just blown. But ages 4 to 6, 50 to 65% of our craniofacial growth and development is already complete. That's just crazy to me. By age 12, 90 to 95% of craniofacial development is complete. So why are we going to wait to age 8, 9, 10 to be getting these kids over to orthodontists? Typically, myofunctional therapists are usually either RDHs or speech pathologists, but we do have some wonderful OTs, PTs, and nurses. Signs of dysfunction. So narrow and vaulted palate or crowded teeth. Again, that tongue should be that driving force. As babies, as infants, we are born obligate nasal breathers. We should be breathing through our nose. That tongue should be resting in the roof of our mouth. When it's not, for whatever reason, allergies, tongue tie, enlarged tonsils, adenoids, what have you, and that tongue posture drops, we don't have a balance between our tongue and our cheeks and our lips. So we have all these unintentional pressures against our dental structures, and that's how we're causing those narrow dental arches. Retruded mandible, malocclusion, long facial growth, so that adenoid type face, facial asymmetry. One of my actually my first myofunctional therapy patient I worked with, her chief complaint when she came in to see me was the asymmetry in her face. And what we found and what we realized throughout the program was she needed a root canal on, I want to say it was like number 19. So she was chewing on the opposite side for so long because she couldn't get the dental treatment at that time due to finances. When she finally got the tooth restored, it just became a habit. So she mainly chewed on one side, so much so that it threw the facial symmetry off. Scalloped tongue, TMD, open mouth posture, low tongue posture, mouth breathing, a tongue thrust swallowing pattern, speech issues, snoring, grinding, any kind of sleep disordered breathing, a flaccid lower lip. So that's like a rolled out or everted lower lip is often a sign of a mouth breather. Dark circles underneath the eyes or any like venous pooling. So that's usually the reason the color is the way it is. It's due to deoxygenated blood when we're seeing those darker circles under the eyes. What about the sleep and myo connection? So some of you already have pretty well established sleep practices. Where, how, why, how does myofunctional therapy, get into this? I believe that any office that is doing any kind of sleep dentistry should have a myofunctional therapist on board in their office, or at least have somebody that they're referring to. Every patient that is given an oral appliance should have myofunctional therapy. We're working on strengthening those oral pharyngeal muscles, improving the muscle control, the muscle tone. We're working on breathing reeducation. These are only going to make these appliances more effective, correcting any oral habits. And again, if they're going through any kind of orthodontic treatment, which when we think about, again, getting to root cause, when somebody has obstructive sleep apnea or any really kind of sleep disordered breathing, typically it's due to the underdevelopment of our jaws, okay? And when we think about why our jaws didn't grow as they should, the root cause of that is poor muscle function. And again, feel free to ask me questions at any time at all. So what about tongue tie? If we're not able to rest our tongue in the roof of the mouth where it should be, it can lead to an obstructive event. if your tongue is down and you go to lay in bed in a supine position and your tongue's not suctioned in the roof of your mouth like it should be, gravity is going to take over and that tongue will fall and block your airway. Okay. So if we have a restricted frenum, it is very important to send them to a myofunctional therapist prior to releasing the tie because we have to start re-educating these muscles. One thing you don't want to do with a patient that already has obstructive sleep apnea is release a tight tissue, give all this new range of motion to a tongue that has no idea what to do with all that new range of motion because that tongue will just fall into the airway and block the airway more. So that pre-myofunctional therapy is so important when it comes to all patients, but especially our sleep apnea patients. When our tongue can't rest in the roof of the mouth again, it's going to impact the way that craniofacial respiratory complex develops. That term was coined by Dr. Kevin Boyd, and I love it because it's not just about the jaw, it's about our nasal cavity as well. They are one and the same, right? Our upper jaw is the floor of our nose and the lateral chambers of our nasal cavity. So as I mentioned, that tongue is really that primary architect of our upper and lower jaw. We need it to rest properly to help develop proper bone growth. I already spoke about being obligate nasal breathers, and I already spoke about, see, I get ahead of myself, guys. I already spoke about our tongue and our lips being our body's own retention system. Another interesting thing too, with the sleep connection is the longer your soft palate is, the easier it is for there to be a collapse in your airway or some kind of airway compromise. And we get an elongated soft palate with the underdevelopment of our maxilla, okay? And the other interesting thing too is when you have a patient with a deviated septum, look inside their mouth and look how vaulted their palate is. As that vault continues to increase, what's up here but our septum, right? So oftentimes we see a deviation in that septum. I already talked about that. This is just a picture of somebody that would breathe through their nose, somebody that breathes through their mouth, and again, how they would grow and develop. We have these beautiful, nice wide jaws here. And then with our mouth breather, we have more of this narrower face, longer face. We have that recessed jaw because that jaw is just hanging open. It's going to swing back and, we're not going to see that beautiful forward growth that we want to see. We can even see this little bump grow on our nose due to mouth breathing. Typically, we're going to see the tired eyes, venous pooling. Again, if you were to think about the maxilla, think about its support that it has to our orbit as well. Okay, so you could even see things in the eyes that will kind of already foreshadow what you're going to see inside the mouth. One of my favorite things is educating. Like if I could just book my patients to talk to them for like half a day, I would love to do that, right? Because there is so much information that I just want to share with these families. Now, of course, we don't want to overwhelm them, so we have to baby step it. But this is all, and especially I feel like I appreciate this so much in a different light as a mother now, because I so often have these mothers come into my office that are crying, right? Either they want to get their child help and they've tried and nobody seems to have an answer and they keep saying they're going to grow out of it. And it's like mom gut intuition, like something's wrong. Or I have a parent in there crying because they're an airway kiddo, right? They had these issues as a child that were never corrected and they're still suffering as an adult and still trying to seek treatment. And they don't want that for their kids. And just the ability to have this knowledge, right? That's all we can do is present this knowledge to people. And then what they do with it is their own, their own doing. But just getting the information out there. And that's why I really created my podcast in the beginning. I do think I have a very heavy professional population that listens to it, but I really created it more for parents, just to be able to be presented with this information. Nobody likes to, go to a doctor and kind of feel like they're crazy in a way, or maybe they, there's some people that have sleep disordered breathing, again, maybe not full-blown sleep apnea, so they're not getting a diagnosis, but they have upper airway resistance syndrome, and they're being told that they need to go see a psychiatrist. And it's like, no, like there is a clear issue here that we can help with. And maybe there is some, emotional and mental health issues going on, but what are the root causes of all of that? If we're not breathing well, breathing is the foundation of everything. A really great book that I recommend for everybody to read, and any of your patients that are in your dental chair is Breath by James Nestor, because he does a really great job at portraying that our bodies will not function well if we cannot breathe through our nose. We have to look at the whole body of our patients that are in our chairs and not just that oral cavity. As I mentioned earlier, I talked about myofunctional therapy as an adjunctive treatment, and this is a slide that I don't always show the slide to my families, but I always talk to them about this because I'm not the only person, right? I'm the function, right? But form and function go hand in hand. I can't teach somebody to rest their tongue in the roof of their mouth if there's not room for it there. I can't teach somebody to breathe through their nose if there's any kind of airway incompetency. If we have tonsils that are, obstructing our airway at 90 to 95%, how am I ever going to get somebody to rest with their tongue on the roof of their mouth? They can't breathe. It is their body's natural compensation to open their mouth and breathe. Otherwise, what's going to happen? I get this a lot too from parents. They're like, one of the things that I assess in my evaluation is I watch somebody chew and eat different kinds of foods and whatnot. And mom and dad, will say, oh, they chew with their mouth open. I'm always having to correct them. I can't stand it. I'm always saying, chew with your mouth closed, chew with your mouth closed. They can't breathe, right? If they could breathe, they would have their mouth shut and breathe through their nose all the time. But if they can't, when they're chewing, they have no other option but to breathe with their mouth open. So open mouth chewing can even be a sign and a symptom of an airway issue. And then tongue ties and things like that are limitations as well. So we have to really address all of this. And that's the other main point I like to get across anytime I'm doing any kind of speaking is it is that multidisciplinary approach that's going to get our patients the best results, addressing the function, addressing the structure, and of course, addressing any limitation that's going to keep us from accomplishing our goals. Okay, so let's get into the fun stuff. At first, any questions before we get into screening in the operatory?
Actually, there are a couple questions in the chat. First of all, Dr. Smith says, great webinar, and wonders what background does one need to be trained as a myofunctional therapist? I would love to have a staff member trained.
A dental hygienist. So assistants cannot do myofunctional therapy, but your registered dental hygienist. And honestly, Dr. Smith, like if you could train your whole team, even if only one of them is going to actually do the myofunctional therapy, it is so important, even you as the doc, to be able to understand myofunctional disorders and how they're going to present. It's just going to create such a difference in your practice. But your dental hygienist is definitely one that you should get trained. And I'm going to actually, at the end, I teach a course to register dental hygienists to become myofunctional therapists, and I'll talk a little bit about that at the end.
And then Kim Thompson wants to know, how long does it take to see results typically?
That's a very great question. So I usually tell everybody, give it at least 4 sessions. Myofunctional therapy is not something that's just a couple sessions. It is a program. I am typically seeing my patients anywhere from 4 months to 12 months, sometimes even longer, depending what's going on. Like if they're going through, like clear aligner therapy, I'm going to see them all the way through that 18 to 24 month plan. So it depends, but I would say to see some kind of progress, I usually give it 4 sessions.
And I'm sorry, did you say how far apart those sessions are?
No. So this is one of the things you're going to find with myofunctional therapy. Nothing is black and white. Everything's very gray. It's going to depend on the patient, but I would say generally you're seeing them once a week or once every other week in the beginning. And then as you get farther along in the program and you work on, say you're working on swallowing patterns, right? I give my patients a little bit longer between our sessions because I don't just want to make sure that they're doing what they should be doing while they're in my office. I want to make sure that they're integrating those things into their everyday life, no matter where they're eating, how they're eating, what they're eating, they're chewing correctly, they're gathering their food correctly, they're swallowing correctly.
Thank you.
Awesome. Okay. So screening in the operatory. So we're going to ask targeted questions. We're going to go over some of those targeted questions. We're going to observe their oral posture and their function. And one of the other things too is even before you call your patient into the room, you should already start observing them. Like watch them in the waiting room, watch them in their natural habitat. How are they breathing? Are they slumped over like this? Is the mouth open? Are they leaning like this? A lot of my TMD patients are leaners, okay? If you do this right now, okay, feel the pressures that you're putting on your face. And also feel what your cheek's doing. Your cheek kind of slides between your upper and lower arches, right? So I always say I write on all of my session sheets for my TMD patients in big letters, hands away from the face, hands away from the face. We're gonna perform a quick functional assessment. And then, of course, as always, we want to document our findings very clearly. So targeted questions that can be very helpful to begin asking patients. I mean, there's so many. I'm just going to go over some of them with you. One of them could be simply, do you breathe through your nose or through your mouth? Do you ever wake up with a dry mouth or feel like your mouth is dry throughout the day? If you're waking up to drink a glass of water in the middle of the night, or you're waking up to cotton mouth, what's that going to tell us? We're most likely breathing through our mouth. Also, when you ask somebody, do you usually breathe through your nose or your mouth? If they say nose, don't just take that is the correct answer. A lot of people are very unaware that they are both, that they breathe sometimes through their mouth or sometimes through their nose, or even that they might be chronic mouth breathers. Sometimes these are things that people never even ever think about. And so when I suspect that they might be more of a mouth breather, but they tell me they're a nasal breather, I will just say, I'll give them, little check-ins throughout the day. Every time you go to send an email at work, I want you to think about how you're breathing. Every time you turn the ignition on in your car, I want you to think about how you're breathing. And oftentimes they'll come back and they're like, you know what, Britt? I think you're right. I think I breathe through my mouth way more than I think I do. Because again, they're not sitting there like, with their mouth slumped open, but it doesn't have to be a mouth breather. Do you experience any difficulty breathing through your nose? You can ask them about their swallowing pattern. Like when you swallow, do you feel your tongue pressing against any of your teeth? Do you notice your tongue resting in the floor of your mouth or pushing up against any of your teeth? One good sign too to know that the tongue is not resting where it should be is look at the incisive papilla. Or not the incisive papilla, I'm sorry, our palatal rugae. If our tongue is resting in the roof of the mouth like it should be, those palatal rugae should be worn down. Now, some people will say, well, how the heck am I supposed to know what worn down palatal rugae are versus prominent? Now that I pointed it out to you, think about how many palatal rugae you see in a day. You'll be able to point out those roadblocks. They look like speed bumps in the mouth. That person never has their tongue resting in the roof of their mouth. Let's see, what else can you ask? You can about orthodontics, maybe they're telling you this is the second or third round of orthodontics that I'm having. Has anybody ever told you that you have a tongue thrust? Has anybody ever told you, that the way you rest your tongue or your lips can really impact the stability of your orthodontics? You can ask about any oral habits that they might have, like nail biting, or if it's a, pediatric practice, thumb sucking, finger sucking. Clenching and grinding our teeth. We want to know that. Those are typically things that we're already, asking. You can ask about sleep. Do you snore at night? Or do you wake up in the morning feeling refreshed? If somebody tells you, oh, like I set the snooze like 3 times before I wake up. If we slept well, not just slept long enough, but had good quality sleep, we should not be waking up feeling unrefreshed. Okay. Do you wake up with a headache? You can ask about, any jaw tension, things like that. And there's way more questions that we can go over. I could even send you guys like a whole list of questions that you can incorporate, into, even if you wanted to present it as like an intake as part of their medical history, or if you just want to have these list of questions so that, again, in the back of your head, you're kind of asking the right things. I can send you the list of questions that we utilize. I want to go over with you the Ferris screener. So this is a functional airway evaluation tool, but you also can utilize this as knowing if a patient needs to be seen by a myofunctional therapist or not as well. So this was developed by Dr. Sarur Sagi, who is an ENT out of Los Angeles. His company is called the Breathe Institute. Cynthia Peterson, who's a very well-known physical therapist. Dr. Audrey Yoon, she is incredible. Dr. Audrey Yoon did a study in, I want to say it was 2021. Yeah, because it was after COVID when things were shut down. Basically what she was evaluating was, because, if we're talking about enlarged tonsils and adenoids, some parents, if you say surgery, they're like, absolutely not. I'm not doing that for my child. I don't want to put them under. I don't believe in removing tissues from my body. People say no. So what could be another option for these patients? So what she was trying to see was if palatal expansion, if phase 1 palatal expansion could eliminate the need to have these tissues removed. Because again, if you're expanding that upper jaw, and we think about what the upper jaw also makes up, right, our nasal cavity, and we're expanding that area, are we going to see these tissues shrink? So that was a very interesting study. And if you want a copy of it, I mean, you could just Google it, but I also can send it over to you. You can find this screener on ferris.org. There's a bunch of versions out there. And again, it was developed to identify any red flag indicators for sleep disordered breathing. But a patient that has sleep disordered breathing also needs to be seen by a myofunctional therapist, as you're going to see. So it used to just be a series of these 6 questions, which we're going to go over each of them. And this was developed for a pediatric questionnaire. And then they added an additional 4 questions for the adult side. So we're going to go over both. But basically what you do is you're going to score. The score ranges from 0 to 6. A 2 corresponds to a mildly increased risk of a sleep disturbance. A 4 is a moderate risk. And then a 6 is a severe risk. And then the adult indicators that we're going to go over are tongue scalloping, tongue overflow, Friedman position, and palatal flutter. All right, so the first one on that beginning sheet for the pediatric one is mouth breathing. You're just answering yes or no. So again, you can ask the patient, but absolutely please observe them. Is their mouth open? Where do you see the primary movement coming from? If we're breathing through our nose, there should be very little upper chest movement. You should see a decent amount of space between your ear and your shoulders. When I say take a deep breath, I don't mean this. I mean deep from down low, like our diaphragm. If you put your hands over your rib cage, like you can put your thumbs behind your rib cage and your other fingers in front, like on your ribs, and you breathe. This is where you want to feel the expansion. Okay, that diaphragm is a 360-degree muscle. So looking and seeing where those breathing patterns are coming from. Can you hear them breathe? We should be breathing very silent. One of the things I tell patients to do, if it's an adult, I'll tell them to record themselves. If it's a child, I'll say to the parent, I want you to go in their room. I don't care if they're 13 years old. I want you to check on them. When you go in there, your child, anybody, should be so silent that you want to walk over to them, stick your finger under their nose just to make sure they're breathing. That's how quiet we should be. There should be no Darth Vaders in our bedroom at night. Are their lips together or apart? Are their lips chapped? Patients that are like chronically applying chapstick during a hygiene appointment or dental appointment, our lips should never be that dry, okay? We talked about that flaccid or rolled out lower lip. That's going to be a sign of mouth breathing. And then, like I mentioned before, make this observation before you even call them back to your room. Mentalis strain, yes or no? So basically you're looking if this muscle has that like stippling appearance. It almost looks like an orange peel. You might see this a couple ways. So for this kid, he cannot even get his lips closed because he has lip incontinence. And as he's closing his lips, you can already see this muscle activate. So you may see it even with somebody's lips open, but if you ask them to close their lips, because again, our goal is to have a competent lip seal, and then you see this muscle activate, I would still say that they have mentalis strain, okay? Usually we're gonna see that compensatory pattern when they're trying to keep their lips closed. Typically, a lot of these patients are gummier smile patients, okay? They have that vertical maxillary overgrowth. Tonsillar hypertrophy. So again, you're doing your EOE, IOE, take a peek back there. Look at that oral pharyngeal width. What do you see? If those tonsils are removed, well, then they're a grade 0. If they're occupying less than 25% of that space, they're a grade 1. If they're 26 to 50%, they're a grade 2. 51 to 75%, they'd be considered a grade 3. Anything over 75% or kissing tonsils, a grade 4. We can't avoid not getting surgically removed grade 4 tonsils. Grade 3 tonsils, again, I usually say when you go to an ENT, ask, how much is my child's airway obstructed? How much is my airway obstructed? If we're seeing like, I say 85%, but it definitely 90 and above, but usually I see 85% blockage. Usually those tissues are gonna have to come out. Okay, but this is how we're gonna grade our tonsil grading. Tongue ties. So On the form, it's either restricted or not restricted. Restricted would be a grade 3 or grade 4, which we're going to go over what that means. And how we're going to look at it, we're going to look at the range of motion with our tongue to the spot. So the spot is that incisive papilla location we talked about, where you say the letter N. You're always going to hear myofunctional therapists say, please bring your tongue to the spot. Yeah. Okay. And then our lingual palatal suction is that other maneuver I had you do. That whole tongue is suctioned on the roof of our mouth. What we're doing, so Dr. Zaghi developed this grading scale. TRMR stands for tongue range of motion ratio. Okay. TIP is going to measure anterior restriction. LPS, which is the lingual palatal suction, is going to measure what we call mid-tongue restriction. So remember when I had that diagram of the tongue and there was the pink part and then there was the green part, right? So the pink part consists of the tip of the tongue and the body of the tongue. If somebody is restricted in the mid-tongue area, so that body of the tongue, it's going to be very difficult for them to elevate the back of their tongue. Maybe they can get the tip of their tongue up there, no problem, but they can't get that seal, okay? This seal is so important for the way we breathe, the way we swallow, stability of our jaw, everything. This is how much of our tongue always needs to be resting up there, okay? So there are little range of motion rulers. I have one right here that you can get in your office. You can laminate them as well so that you can reuse them. I would laminate them, but they have this little notch. Oh, you guys can't see because of my screen's blurred. Hold on. Sometimes I don't even know how this blur gets on. Okay. Whoop. Okay, so little range of motion ruler. You put it on the incisal edge, and then you're measuring how wide they can open. You can get actual measurements and get these and laminate them. God bless you. I don't have the patience to do that. Or you also can visualize it, which is what I'm going to show you on this next slide. So we're going to watch 2 videos. This first video, I'm going to ask this little girl to open. So this is what you should do to your patients. You should say, can you please open whatever your comfortable maximum opening is? We don't want anybody straining. And elevate the tip of their tongue up. But I want you to keep your jaw still. So if I were to do it, my jaw doesn't move, right? I don't have to close my jaw to get my tongue up there because I have good range of motion in my tongue. For somebody that's more restricted, they're going to do one of 2 things. They're either going to listen to your instruction and keep their jaw open, but not touch the roof of their mouth because they can't, or they really want to touch the roof of their mouth because they know that's what you're looking for, but they have to close their jaw more than 30% to get their tongue to touch. Either way, you're going to see that restriction. So first video. And then I want you to stay open that big, but I want you to try to touch the top of your mouth with your tongue. So see how she can't get there, but she kept her jaw still. And you can see that tissue blanch, right? Like you were able to see that tissue got very taut. And then this little boy, big, he closes his jaw. I want you to bring your tongue up to the top to get his tongue to touch up there. Good. Open. Okay. Either way, we're seeing that restriction in the range of motion. Other things that we might see, and I have photos of all of these. If you want to take a picture of this slide, you can, just to know those different appearances. But I'm going to show you photos. One thing I want to say is a tongue tie is only a tongue tie if they are functionally impacted. Even if they present with a wicked heart-shaped tip tongue, which I'm going to show you, but they function okay, I'm not going to recommend a release because why? We're not just going to cut tissue, right? So they have to be functionally impacted. But these are just little indicators that send off like alarms, like, ooh, okay, I think there's a restriction here. Maybe they're being functionally impacted. I need to refer them to a myofunctional therapist. So here's that heart-shaped tip right at the end here, okay? The other thing that you can see here is this depression in the blade of her tongue can also be from, as she's extending her tongue outward, the frenum is pulling on the underside. This is the Eiffel Tower attachment. When you see this Eiffel Tower attachment, it is almost always, pretty much always, indicative of mid-tongue restriction. Now, mid-tongue restriction, for some of you that are familiar with tongue ties, this might be a new term for you. For a long time, we were calling them posterior tongue ties. They're synonymous. Synonymous. I think I said that word right. Dr. Zaghi recently had changed the terminology because when we were saying posterior tongue ties, it was very confusing to patients where they thought like their tongue was tied like all the way in the back of their throat or something. And what a mid-tongue restriction is, it's just deeper submucosal, and it's going to, again, impact more the body of the tongue versus the tip of the tongue. So a patient that presents with this Eiffel Tower attachment, they might be able to stick their tongue and extend it all the way out. They might even be able to touch their nose for all I know, but they can still be tied if they cannot get the mid body of their tongue to elevate. Okay, I hope that makes sense. Here's another example of that Eiffel Tower attachment. It's attaching on this alveolar ridge versus into the floor of the mouth. You can see the taut tissue here. This is a pretty anterior tie. This photo is very interesting. When we look at tongue ties, we also want to look at overall body compensations, okay? These two photos were taken one after the other, okay? I should have wrote the numbers down. If I were to look at this, I would guess that this range of motion is probably like, it's very good. So I'm going to say like 35 millimeters maybe. Then all I did in the next photo was see how this floor of the mouth is pretty elevated. I took my finger, I applied a little bit of pressure to the floor of the mouth, and she no longer was able to touch the roof of her mouth. And you can also see this little V shape right at the tip of her tongue here, that little indent is from that pull, from that restriction. So floor of the mouth lifting is something that we look at as a compensation, okay? Does her tongue really have the ability to elevate this much, or is she recruiting all these other muscles in the floor of her mouth to get her tongue to do that motion? Okay. Tetheral tissues, I'm not going to go through every single one of these because we can have a whole class on tongue ties, but what we see impacted, we can see sleep issues impacted, craniofacial respiratory complex development, so the ability to breathe well, the way our jaw grows and develops, feeding in infancy, also feeding throughout life, grazing, picky eaters, choking, gagging on foods, only liking soft foods, speech issues, and then other issues would be like jaw issues, postural issues. Let's see, what else do I have on there? Digestive issues, we talked about that, like the constipation, sometimes IBS type symptoms. But again, tongue tie is a whole other long topic to talk about. Why it's important and why it can impact the whole body. This is your deep frontline fascia runs from the tip of your tongue all the way down to your toes, okay, in one connective piece. So if we have restriction all the way like high up in the chain in our oral cavity, it makes sense that we're going to see all these other influences, negative influences throughout the body. This is a before and after of a little boy that had his tongue tie released, okay? Clearly, these were his before photos. You can see how much his posture was impacted. And then after he had his tie released, did his myofunctional therapy, he got body work by a cranial osteopath. These pictures were taken like a day before his release and 2 days after his release. And this is how much change that he got. These are just before and after pictures of a patient that was tied. You can see the complete separation between his tongue and the floor of his mouth and how beautiful that is. When we are assessing tongue function in hygiene school, in dental school, we learn if a patient can stick their tongue out past their lower lip, they are not tongue-tied. As you can see on this, extension or protrusion of the tongue is only one function that the tongue needs to be able to do. So nothing irks me more than when I have a child that is in my office and I assess them and I feel that they have a restriction. Now, I can't diagnose as a hygienist, but I see that they're being functionally impacted. The way they breathe, their tonsils are massive, they have no spacing between their teeth, they're not sleeping well, maybe they're wetting the bed past a certain age. And I see that they have a tongue tie. Again, I can't say that to the patient because I can't diagnose. And then they go to see their pediatrician or they go to see an ENT that isn't one of the ENTs that I work with. And they come back to me and they say their tongue's fine. And I ask, well, what did they do? Well, they had him stick his tongue out. Well, that's great, but I asked him to stick his tongue out too. And if he read my report, he would read that there was no issue with extension or protrusion, but maybe issues with elevation or lateralization or cupping. Cupping of the tongue is the ability, basically your tongue creates a bowl like this. Your tongue has to be able to do that to receive food and liquids and contain foods and liquids, okay? Then we have to talk about that lingual palatal seal. So again, not just getting the tip of the tongue elevated, but the rest of the tongue. And then mandibular differentiation is the ability for you to move your tongue in isolation of your jaw. That is extremely important for the health of our joints. Also very important for speech. But when it comes to our TMD patients, it's usually very poor mandibular differentiation. So what that would look like is instead of this, I might see, or if they were to protrude their tongue, like their lower jaw would jut forward with it. Or if they were to elevate their tongue instead of this, I might see, I'm bad at doing it, but they might actually close their jaw with it. Dental wear, yes or no. And then you can obviously denote if there's abfractions, gum recession, attrition, whatever it is. This is just a study that I can also send you guys, or again, you can Google it. The PDF is right on here. But Dr. Gerald Simmons is a sleep physician. Dr. Ronald Pren is a sleep dentist. And basically, this study just shows how bruxing at night is really our body's natural protective mechanism to open our airway. If we think about why we give patients these sleep devices that literally take the jaw, protrude it forward to open the airway, and then we think about the mechanism of the muscles that are involved in bruxism, it's the same thing. It is to open our jaw, protrude our lower jaw forward. So the idea is as we're bruxing at night, it's really your body trying to find an open airway for you so that you can breathe. Narrow palate, yes or no? Something simple you can do, grab a cotton roll. Cotton roll generally measures about 37 millimeters. Stick it up between 3 and 14. In a perfect world, let me go to the next slide. In a perfect world, we would all be walking around with about like 40 millimeter intermolar width. There are not a lot of people walking around with 40 millimeters intermolar width unless they have gone through some form of expansion, okay? If you're stuffing that cotton roll up there, that's a good, pretty good indication that they did not grow adequately, okay? So these are the categories that they have on this form. You are severe if you're measuring less than 32 millimeters. You also can just take like a caliper and literally measure the distance between the 3 and 14. You can take a wax bite, have the patient bite in it and measure. You're measuring from mesiolingual cusp to mesiolingual cusp of 3 to 14. And then you're moderate if you're 32 to 34 millimeters, 34 to 36 would be considered mild, 36 to 38 is average, and then above average, 38 to 42, which again, generally we don't see. When you're measuring pediatrics, usually you take 24 millimeters and add the child's age. In a perfect world, by age 5, really by age 4, we'd want to be about 30 millimeters. By age 8, we'd want to be about 35 millimeters. Okay. So when you're working with an adult that has a 32 millimeter intramolar width and you're like, oh, wow, you should have been 30 millimeters by age 5. And here you are 42 years old and you are only at 32. Again, those patients, you're going to be stuffing that cotton roll in. So you would answer yes or no on that. Tongue scalloping. Is it normal, mild, moderate, or severe? Tongue overflow. When somebody holds a lingual palatal suction, basically you're looking how much of the tongue is overflowing on those occlusal surfaces. Your tongue should fit in your mouth like a car fits in a garage, okay? There should be no palatal overflow if your jaw grew adequately. Friedman tongue position. So essentially we're looking like what structures are visible back here. We want to be able to see all the way down to the apex of the uvula. I usually use the uvula as like my guiding light here, but we're also looking at like the tonsils and other tissues back there. But you can see how as we get to grade 4, you can't see any of the uvula and all you're really seeing is the hard palate, right? We can't see any of the soft palate. You can kind of see the base of the uvula in grade 3. Partial, very small partial view of the soft palate. This is just a patient that I wanted to show you guys. This was my first myofunctional therapy patient. If I could go back now, I would put the flash on in this photo because we can barely see. And this was taking this patient from a grade 4 all the way down to a grade, I'll even say a grade 2, but it's really a grade 1. It's like a grade 1 to a grade 2, just through myofunctional therapy. Because what are we working on? We're working on strengthening, toning, controlling the muscles, those oropharyngeal muscles, the tongue, the base of the tongue. Palatal flutter. So this is a test that's used to predict how likely the results of treatment would be in patients who snore. So what you want to do is start by asking the patient to produce a snoring sound while their mouth remains open. So, okay. Then you're going to have them perform a lingual palatal suction and attempt to make that snoring sound again with their tongue pressed firmly in the roof of the mouth. That's what a lingual palatal suction is. If they are quiet with their tongue suctioned in the roof of the mouth, then they will probably snore much less if they could learn and basically just become a closed mouth sleeper, keeping the tongue in the roof of the mouth and breathing through their nose. And they would probably do well with an appliance. If they're negative, then they should be evaluated for tongue space, making sure that there's enough space up there to rest their tongue. And they might need to consider like palatal expansion, other interventions, maybe it's weight loss, oral appliance therapy, CPAP, jaw surgery, whatever they need. Other observations, you can watch a swallow. So when I watch somebody swallow, I don't want to know that I shouldn't be able to tell that they're swallowing unless I was watching their neck area, right? Because we're going to see that hyoid bone move up and down. Let me play this. So see how she incorporates all of those perioral muscles. You were able to see the blanching, the stippling in her mentalis muscle as well. She's pursing her lips. Some patients will like nod into their swallow. That's considered a compensation. These are just videos of very evident. This is a very evident tongue thrust. This one's not so evident. So remember I said that a patient doesn't have to have an anterior open bite like this little boy did to have a tongue thrust or have poor tongue posture. This little boy has a very deep bite, but he still has
I'm going to have you swallow for me.
It's more of a posterior tongue thrust. Okay. The other thing are orally defensive patients. So those patients who are due for a full set of films and they're in your schedule and you're like, oh no, not in the mood for this today. There's a reason that they're orally defensive. Those patients where you're scaling their lower anteriors and you like literally have to like stand up to get their lower lip so you can pull it down so you can actually see what you're doing. The gag reflexes, those are all a way for us to protect our airway. In myofunctional therapy, we help to desensitize those areas. So how to introduce the concept of a myofunctional therapy screener. So you want to make it clear, you want to make it approachable, and you want to focus it on the patient's overall health. You want them to feel very comfortable with the fact that you're introducing a new topic, and you want them to see the value in it, and you want them to be proactive, right? You want that it should be part of our literally every single dental appointment. It's a very quick screener to be able to do. And then step 1, you are going to start with a relatable question or observation. This is going to help make the conversation feel more personalized and relevant to whatever, is going on with the patient. So you identify a potential issue that they might already be aware of. This could be something, any kind of oral health condition, oral habit, any discomfort they're going through. So an example, I've noticed some signs that may indicate your tongue posture or breathing habits could be affecting your oral health and your overall well-being. Do you ever feel like you have trouble breathing through your nose or notice any jaw discomfort or teeth grinding? Very simple questions, and think about how many patients you see in your practice that would most likely say yes to that, okay? Once we capture their attention, we can introduce what the myofunctional, screener is. It's a simple, non-invasive tool used to assess how their muscles are working, their tongue, their lips, their jaw, how they're functioning. So you can say something like, we use a quick screening tool called a myofunctional or an airway screener, you can just say, to assess how your tongue, lips, and jaw muscles are working together. It helps us understand if there are any habits or issues like mouth breathing, tongue thrusting, any swallowing issues that might be impacting your dental health and really even your overall health. Step 3, highlight the connection to oral health and their overall wellness. Help them understand why this screening tool is important by explaining that broader impact that it has beyond the dental chair. You can say something like the way your muscles work in your mouth, how you breathe, swallow, and even the way you hold your tongue can have a big impact on things like your bite, your jaw health, and even the quality of your sleep. Some of these muscle habits can lead to issues like misaligned teeth, jaw pain, or even difficulty breathing while you sleep. This connection is going to make the screening seem more relevant and less like, this is just something new that I'm trying to run by some of my patients. Step 4, reassure the patient that the screening is simple and non-invasive. Reassure, right? Nobody likes anything new. Nobody ever wants to feel like they're being sold. We know that's not what we're doing, but we need to reassure the patients what is going on, right? So we want them to be comfortable with this idea, and we want them to, again, know it's simple, pain-free, non-invasive. It'll take just a few minutes. It's very straightforward. It doesn't involve any extra procedures or discomfort. I'm going to take a look at how your tongue is functioning, how your lips are functioning, the way they move, the way they rest, and if there's any signs of habits that could be impacting, again, whatever issue they're presenting with their teeth, misalignment of their teeth, breathing, maybe their periodontal disease, whatever. It's similar to a dental checkup, but we're focusing more on your muscle function. Explain the benefits of myofunctional therapy. Also non-invasive, pain-free. It's a natural way to address the root cause of oral and overall issues. It's preventative and proactive. So you can let them know if I find any issues. The good news is that myofunctional therapy can help. It involves a series of simple exercises to help you retrain your muscles in your mouth, which can help improve things like whatever they need improvement on, their bite, bruxism patterns, reducing jaw pain, breathing patterns. It's non-invasive to help your muscle function, which can make a huge difference on your overall and long-term health. And really save them money. Chronic illnesses, guys, right? Chronic issues, the amount of money people spend. If we can address these root causes, we can save them a boatload of money. Provide examples of what myofunctional therapy can help with. So it's not uncommon for people to immediately, it's not uncommon for them to not want anything to do with this, right? To not understand the connection, sometimes not even to hear it. We know, I feel like as dental professionals, we're very good. I know we only have a few more minutes and then we're gonna do the Q&A, so I'm gonna go through these quickly, I promise. But I feel like one of the good things as dental professionals, we're very good with reading our patients. When I am working with new myofunctional therapists, when they graduate, they're so excited because they have all this awesome information they want to share with their patients that it's like word vomit. And sometimes it's the first time that somebody's hearing these things and it's very overwhelming. And I know the second I get overwhelmed, my listening ears go completely off. Last night, I had a very stressful day with the girls. My husband came home. He's trying to explain some kind of math to me about, I don't even remember now. That's how much I wasn't listening. I literally wasn't listening. And he looked at me and he's like, I feel like you're looking at me, but you're really looking through me, aren't you? And I'm like, yeah, I have no idea any word that you just said. I couldn't even repeat one of them back to you. So again, we don't want to overwhelm our patients. So it's not uncommon right away to not be able to have a more deepened conversation, but that's okay. Note it that you had you started the discussion with your patient, and it's always something that you can revisit in a few months. You can always leave them with a website to check out, a podcast to listen to, a book to read, whatever it might be. But anyway, so back to getting to how to provide them with examples of what Myo can help with, you can say something along the lines of, if you breathe through your mouth instead of your nose, this can cause your mouth to dry out, which is, an increase for cavities or gum disease. Myofunctional therapy helps you to retrain the way you breathe, so you're able to breathe through your nose more comfortably, which is healthier not only for your mouth, but your overall health. Okay, and these are just a few other examples. Explain the next steps, right? You don't just want to point this information out to them and be like, okay, see you in, 3, 4, 6 months, whenever they're coming back in. Let them know that if this screener indicates any issues, reassure them that the process is manageable and I'm going to help guide you to the next steps, get you in touch with exactly who you need to see. right? We're going to refer you to a myofunctional therapy specialist or whoever, you need to refer them to, and reminding them again that the therapy is gentle, effective, natural, pain-free, and done in conjunction with whatever dental treatment they might be going through in the office. As always, encourage questions, provide resources. Like I mentioned before, video links, podcasts, YouTube, pamphlets. You could have brochures in your office. Let them know if you have any questions. Please feel free to reach back out. You can give them your hygiene business card, and let them know, maybe you can even have like a monthly webinar or something, talking about airway issues, just to start having the conversations. Anybody that might be interested, we're hosting this every first Monday of the month. We're hosting, like a Myo Monday or something like that. I don't know. Okay, so this is an example script for introducing the screener. I've noticed that some of your oral habits could be affecting your dental health, like breathing through your mouth instead of your nose, and maybe experiencing jaw discomfort. To make sure we're addressing all aspects of your health, we use a simple screener called a myofunctional screener. It takes a few minutes. It helps me assess the way your muscles work and are functioning. These habits can impact things that we don't think about, the way our bite is, the way our teeth align, our jaw health, and even the way we sleep. If we find something that could be improved, we can refer you to a myofunctional therapist, specialist, whatever you want to call us, who will guide you through simple exercises to help correct those habits and improve your comfort. It's quick and an easy way to ensure optimal oral health and could save you from bigger issues down the line. This just talks about the importance of building a network. So like I said, I'm very rarely the only person that's involved in a treatment plan. And this just talks about whoever you're making a referral to, just keep that communication, seamless. So you can have follow-ups. You want to be an active part in this multidisciplinary team, regardless of who you are, whether you're the doctor or you're the hygienist. So just stay involved, follow up, ask questions. I love asking questions. That's just the best way for us to learn. Any referral that you make. So, of course, with anything, there's always that initial investment, but I hope that after listening today that you can see the long-term benefits of introducing myofunctional therapy, whether you have a myofunctional therapist in the office that's trained or you're referring out to a myofunctional therapist, and really that ROI, like I mentioned, saving valuable chair time, saving people time in, orthodontics, if you're a practice that does clear aligner therapies, whatever it might be. There's always going to be a benefit to working with a myofunctional therapist. If you're interested in becoming a myofunctional therapist, or you're a doctor that wants to get your hygienist trained and you want to know how to better support your hygienist, we have had plenty of doctors come and take the course either on their own and then send their hygienist or along with their hygienist. I do teach a course through Airway Health Solutions. I teach a variety of courses, but I want to just kind of focus on the introductory course right now. And if you have any questions about the other ones, you can always feel free to reach out. If you scan that QR code, it will take you to our website. So my introductory course, you receive 28 AGD credits. It's an 8-week course. When you register, you gain access to about 9.5 hours of learning material. Okay, we have special lectures by Dr. Moralia and Dr. Kevin Boyd, which are big trailblazers in airway health and dentistry. And then once the course starts, every week, so every Wednesday for 8 weeks, there's a new lecture that's dropped in your Dropbox folder. You are able to listen to it at any time. I like doing it that way instead of a live lecture, because what I would have done with my first Myo course to have been able to like pause my instructor, rewind my instructor, slow down the speed, speed up this, like whatever. It's just, I think it's fabulous. So you'll be able to do whatever you want with me on the screen. But it's so helpful, right? Like maybe we do the live course and your child's screaming in the background and you can't focus. You can watch it in your own time. Then, so those are released on Wednesday. On Monday nights, we do meet live for a virtual Q&A from 8 to 9 p.m. Eastern Standard Time. Everything is recorded. So if you cannot make the Q&As due to, time difference, I don't know, anything, totally fine. You can email me your questions. I'll make sure to get your questions answered. One of my favorite parts about the way I designed the course is our final week. You'll see as case study presentations. It is not me presenting case studies. It is you presenting case studies. And this is really cool because oftentimes we leave our first myofunctional therapy course and now we're starting to work with a patient and it's like, ugh, don't know what to do. I'm so uncomfortable. So you're already leaving the course, already starting to work with your first myofunctional therapy patient. Just some bonus things. We have a WhatsApp group. I chit chat with, our community all day long. I host quarterly Q&As in our private Facebook group. We host monthly case reviews. So similar to the case study week, you can always bring, a case you need help with, figuring out, troubleshooting. Maybe it's one that you're proud of, anything like that. But there is ongoing support, which is so important. If you want to find me, you can visit my website, www.ctorofacialmyology.com is my myo practice. The myohygienist.com is my teaching side of things. Please feel free to email me. This is my personal cell number. Take a picture of the screen. If you aren't curious if a certain patient would benefit from myo, please feel free to reach out. Anything I can do to help, I'd be more than happy to. And thank you for listening.
Thank you. That was fabulous. So much
you.
information. Oh my gosh, you covered a lot in 90 minutes.
Thank you. Yeah.
And if anybody wants to ask a question, you can do it one of two ways. You can either turn on your camera and your mic, or you can chat it right into our little chat box there. And I'm actually going to post the information for getting the CE in the chat box as well. So go ahead and find that. There we go.
Oh, Stephanie's on here. She's one of my former students. Hi, Steph, if you're still on. I don't see your name anymore, I don't think.
Yeah, now that you're not screen sharing, you can actually see that there are participants here. So Kelly just asked a question. Is it typically recommended that a baseline level of progress is made with myo before adult Invisalign should begin, or can it be completed during/after? I understand it depends on severity / what is being corrected. Just wondering the typical workflow.
Yeah, this is a really great question. So that collaborative approach is going to be really important. I like to also know what the docs I'm working with, what their typical protocol is, but I would say as a myofunctional therapist, I would like to start, I usually phase their treatment. So I usually have like a phase 1 and a phase 2. So I would love to get started with them at least at the very beginning of their treatment, or before is fine too. Because if we can get those muscles functioning at least a little better, it can help guide that progress and progress them quicker through their clear aligner therapy. But also with that being said, like I said, if it's like a 24-month treatment plan or something, I do want to be with them at the end still, because sometimes we have to fine tune things, like, right, if we're getting more tongue space, like we might have to, okay, maybe we're able to get more of the tongue up now than we were before because we created more space. So there's always things that might need to be worked on. So I might see them as phase 1, put them on a bit of a maintenance where they're just doing a little bit of myo and not actively seeing me, but I'm always there, if they want to email or whatever, and then picking up again for active phase 2 closer. But you definitely want to finish your myo program before they're done with their treatment.
Thank you. Anybody else? Feel free to turn your mic on and your camera or chat in the box. And Brittany, if you want to add any links to the chat, you can do that too. I know you provided everybody your contact information and websites, but if you want to, feel free.
And another thing too that I didn't talk about as far as myo is it can be done virtually. So we treat patients globally. Yeah, which is really cool. And people usually say, well, is it as effective? As long as the patient has a strong internet connection and is sitting in a well-lit room, there really is no reason that we shouldn't be able to do what we need to do and get done what we need to.
Oh, that makes it so much easier for folks. What would you say the ratio is between your in-person versus virtual?
So honestly, a lot of people, even like my local people in Connecticut, will come for their evaluation and then switch to virtual. So we have,
Interesting.
yeah, I mean, we're still probably like maybe 60 in person, 40 Virtual, definitely more evaluations in person, but so many people choose to go virtual because, again, it can be done. The only time I don't recommend it is like really small kids. It's harder to keep their attention.
Sure.
However, COVID did help because kids were on school, online for school. But
Mhm.
like we do mini mile with like 3, 4-year-olds. Those kids, if I can see them in person, I rather. But I do, again, I see kids all across the country. So a lot of times, even with that age group, like 2, 3, 4-year-olds, it's usually more parent education and parent involvement than the actual child, anyways.
Sure. What is your typical, like, a day in the life look like? Like, how many patients do you see?
Yeah, so, well, currently I'm not back full time still from my maternity leave, but prior to going out maternity leave, I mean, my day was crazy busy. So I don't advise doing what I did, but yeah, I would see like 14, 15 patients a day. It was crazy. But generally, I would say myo sessions are about 30 minutes. You want to give yourself a buffer, which is what I didn't do, which I advise doing. Definitely give yourself a buffer. So if you can book like, a 10, 15-minute buffer for yourself, I think that could be very helpful. Mix in some evaluations there. The evaluations take longer. Evaluations are usually, I would say, for a well-seasoned therapist, an hour; for a new therapist, like 90 minutes to 2 hours. And you want to keep in mind too, like there's only going to be so many new patients you can see a month because remember, Myo's not just one session, 2 sessions, you're graduated, it's a program. So maybe, you see 4 patients the first month, that seems really slow. But over the next couple months, now you're seeing 12, 16 new patients that you have to fit in your schedule. It's not uncommon for especially dental hygienists to start doing myofunctional therapy part-time until they build their schedule. So they'll still do hygiene and do myo. If you're doing myofunctional therapy in your dental office, please, please, please separate the two roles. You almost want to be thought of as two different people, like Brittny Murphy, the dental hygienist, Brittny Murphy, the myofunctional therapist.
That makes sense. When I was listening, I was thinking just how many people could benefit from this in general.
I think
Yeah.
everybody could use myofunctional therapy.
I know. It was funny. My partner works from home and also next door. And I saw him like listening before I put my headphones in and like doing some of your.
And you'll see that, like, if you evaluate a child, I promise you the dad or mom or caregiver will be in the background like, I can't do that. It's hysterical.
I can't wait for my kids to get home so I can evaluate them.
Exactly. So Abby has a question. How does OMT help desensitize the gag reflex?
That's a great question. So, we do a lot of work with the vagus nerve. So the vagus nerve and making sure that, that's activating well will also help with the gag reflex. But there's certain exercises that we do. We start not slower, what am I looking for? More forward in the mouth. Like we use like plastic utensils to kind of scrape the tongue, scrape the palate. And every week we're kind of getting further and further back to the point where we're diminishing that gag reflex and, we're able to stick the plastic fork or whatever and scrape all the way down the tongue as if we're cleaning it. But vagus nerve has a lot to do with the gag reflex. I want to share also my Instagram page because there's a lot of good information on there. And then I can share with you my podcast link too.
Thank you. Oh, there you are. Okay, cool. Awesome. And then Alicia says, not sure if you already said this or not, but do you teach the business side of Myo in your program?
Yes. Yes. It's so important, right? Especially if you, I mean, even if you want to do myo in your dental practice, you still want to protect yourself and protect your intellectual property and all the, investment you're going to be making in forming this myofunctional therapy program in the dental practice. But yes, we do go into that. It's so important because I feel like us hygienists, like we're geared towards science, right? Like, so for me, the business stuff in the beginning went right over my head. So basically, I'm teaching you not to do all the things I did, right? Learn from my mistakes, and
Yeah.
I'll tell you all the good stuff.
Awesome. I love that. All right. Well, if we don't have any other questions, let's go ahead and wrap up and give everybody their Friday.
Awesome. Well, again, thank you everybody for your time. This was wonderful.
Thank you. We appreciate you so much. Hopefully you'll come back.
Always.
All right. Thanks. Bye, everybody.
Bye.